Walwaikar. Dr. Rohit Walwaikar is a active member of Global Psychiatric Association, is a psychiatrist from Maharashtra, and his primary area of work is perinatal psychiatry, neurodevelopmental disorders. He will be talking about non-psychotropic management and neurodevelopmental disorder today. Over to you, Dr. Rohit.
Thank you.
Rohit, you can share your slides. Okay, that's fine.
Yes. So we're coming to talk about non-psychiatric medications in neurodevelopmental disorders. I am currently a consultant psychiatrist at Empower, which is a unit of Aditya Birla Education Trust. And my primary station is in Maharashtra and Goa, and I look after collegial students, PhD students. Right now, my current practice population is being them, which is also in alignment with my special interest in neurodevelopmental disorders. So today we are going to talk about primarily the objectives of this presentation would be to explore the role of non-psychiatric medications in neurodevelopmental disorders, to discuss evidence-based use across specific disorders under the gamut of neurodevelopmental disorders. We'll put a special focus on cognitive enhancers in ADHD as well as anti-irritability agents in autism spectrum disorders, which are not mainstream psychiatric medications. We'll go through the operational definitions in the next few slides and the neurodevelopmental disorders overview and the diagnostic categories. So under the gamut of neurodevelopmental disorders, we have intellectual disabilities, autism spectrum disorder, attention deficit hyperactivity disorder, and communication disorders, specific learning disorders, motor disorders, which includes Tourette's and developmental coordination disorder. Common features we shared across the neurodevelopmental disorders, they have onset and developmental periods, and it has significant impact on academic as well as socio-occupational functioning. To define non-psychiatric medications, they are not, these are the medications which are not really classified as a primary psychiatric agents, originally developed for other medical indications such as for cognitive enhancers with respect to example of which would be modafinil, acetylcholinesterase inhibitors, anti-epileptics such as valproate and lamotrigine, antihypertensives such as clonidine and guanfacine, which are alpha-2 agonist, and anti-inflammatory or metabolic agents such as N-acetylcysteine and metformin. They are mainly used off-label in many pediatric entities which show adjunctive treatment response, which are seen across a lot of gamut of neurodevelopmental disorders. We'll talk first about ADHD, wherein we are talking about cognitive enhancers in ADHD. They are specifically used when stimulants are not tolerated and in case of partial response to the first-line medications, often used as an adjunctive treatment to patients who are already instituted on stimulants or non-stimulants. Cognitive sluggishness is something which is, a common indication for using cognitive enhancers in case of sluggish cognitive tempo, which is the most usual complaint, which is seen in case of executive dysfunction, which is seen with neurodevelopmental disorders in both adult as well as pediatric populations. Major compounds which are having maximum, evidence in literature would be modafinil, amantadine, pyracetam, oxiracetam. Now, modafinil is a wake-promoting agent. Mechanism of action is definitely dopamine reuptake inhibition, which is a very indirect way of going ahead with things. Improving attention and executive function is seen very commonly. However, caution has to be executed when with respect to FDA warning, with respect to the Stevens-Johnson syndrome risk in children. Amantadine. Now, amantadine has a very epiphanious story wherein, it was seen as an anti-flu agent as well as an anti-Parkinson's, but as a very core neuroscience oriented way, it is a dopaminergic and NMDA antagonist, which may help in improving attention. However, it has limited pediatric data. Piracetam oxiracetam are nootropics which are used off-label in some countries. Now, another important thing about nootropics is that both natural as well as synthetic nootropics are most commonly used off-label as per the availability and as per the orientation of the person of the service user. I have a lot of clients who are using caffeine as one of the nootropics without which they cannot get off the start of the day. Now, that is one of the natural nootropics. When we are looking at synthetic nootropics, piracetam deserves actual mention. It's used off-label in some countries. However, mechanism is unclear and it has limited evidence in ADHD. Modafinil is the one which has a maximum amount of literature evidence per se. We're looking at randomized double-blind placebo-controlled flexible dose study was taken up with modafinil at the doses of 170 to 425 mg per day, which significantly improved ADHD rating scale 4 scores at both school environment as well as home environment, with the responders percentage as high as around 52% versus 18% for placebo, which was seen according to CGI-I scale. There was an RCT in 2006, which included 6 to 15 years old, which was started on modafinil by Kabazi et al. At modafinil was started at 200 to 300 mg per day, which was effective in reducing ADHD symptoms compared to placebo over 6 weeks. The third study, which is deserves a mention, about an open label study which was carried out in 11 children. However, a small sample size, it improved attention task in TOA, according to TOA, and ADHD ratings significantly has improved. Other non-psychotic agents in ADHD would be guanfacine, which are guanfacine XR, extended release, which is used as an alpha-2A agonist. It improves hyperactivity and impulsivity. Clonidine, seen to be sedating, but it helps with sleep and tics. Iron zinc supplementation is useful if deficient, and L-carnitine is explored in small studies. A bit of a mention about iron zinc supplementation. Iron, if you see, according to the tyrosine and serotonin reuptake serotonin synthesis pathway, iron is one of the most important things. When iron is deficient, proteins are deficient. If you're going ahead with supplementation of iron, then definitely I have seen very modest improvement with respect to iron supplementation in my clients. Zinc supplementation is something which is quite gray area, I would say. In my experience, what I do is copper zinc supplementation. I copper zinc estimation is what I start with. Thereafter, I look at the zinc copper ratio, and if at all zinc copper ratio is to be maintained in a proper normal ranges, then it gives you an adjunctive boost towards the already started stimulants in ADHD. They are useful as deficient, and L-carnitine is something which is explored in small studies with little evidence to support. Talking about coenzyme Q and omega-3 fatty acids, EPA-DHA and coenzyme Q, Gamal et al. In 2022 evaluated CoQ efficacy as an add-on treatment in 60 children with Connors PRS, CPRS showing improvement of around 33.87% in group 1 versus 18.2% in group 2. Also, it was noted that the population, the group 1 with CoQ as an add-on treatment showed shorter time to improve with respect to the ADHD symptoms, which were evaluated in Connors PRS. Second study of notable mention is an RCT in Spain by Martin et al., wherein 60 children were enrolled in an RCT who were aged around 6 to 16 years. They were having an around 8-week intervention with one diet, one group on Mediterranean diet, one group on only omega-3 fatty acids, and the third group as a combination of Mediterranean diet and supplementation of omega-3 fatty acids. Here, it was clearly seen that omega-3 supplementation was effective while diet was not alone, and in combination, it was not effective as well, but omega-3 supplementation showed definite improvement. However, one of the critics of this particular study was a low sample size and the rigorousness with respect to the understanding of Mediterranean diet and the supplementations would be a little bit sketchy. But this is, however, an RCT which was quite a notable mention. We're coming to autism spectrum disorder. Brief overview about the core deficits has social communication and restricted repetitive behavior are seen as core deficits. It also shows high comorbidity with intellectual disability, ADHD, irritability, and which are used for are for aggression, tantrums, and self-injury. Now, as we all know, aripiprazole, brexpiprazole is something which is a psychiatric medication, But right now, if you're looking at things, then the non-psychiatric medications is something that we will be looking at across in the further slides. Anti-irritability agents which are used in autism spectrum disorder, one of the most important molecules is N-acetylcysteine. There was a pilot RCT in 2012 wherein NAC was given at 2700 mg per day over 12 weeks by Hardhan et al., which significantly improved ABC irritability scores in autistic children, which were at around 3 to 10.7 years. Another notable mention of risperidone plus NAC at 600 to 900 mg per day led to significant reductions in an adjunctive therapy trial in 2015, which was performed in Johns Hopkins. And it was seen that hyperactivity and non-compliance were reduced, whereas irritability symptoms were also reduced when compared with risperidone and placebo over 10 weeks duration. 2015, another RCT mentioned about NAC with at 1200 milligrams per day with risperidone was showing significant drop in irritability ABC scores after 8 weeks, and this was well tolerated. Meta-analysis in 2020, which pooled RCT data of 8 to 12-week interventions, showed NAC significantly reduces irritability and hyperactivity and improves social awareness in ASD youth, autism spectrum disorders youth. Research schoolers cysteine at around 400 to 600 mg per day for 8 weeks reduced irritability and stereotypic hyperactivity behaviors and improved their social responsiveness also. Coming to propranolol as another molecule as an anti-aggression, anti-irritability agent in autism spectrum disorder. 2024 RCT, quite a recent RCT, which was a pilot double-blind placebo-controlled RCT, showed high-dose propranolol up to around 200 milligram TID in 12 to 19 years old with chronic aggression in ASD, achieved around 50% symptom reduction with CGI-I and 37% reduction in ABC irritability. The pros is it was shown to have large effect sizes and it was considered to be safe. RCT in 2023, propranolol was given for 12 weeks, improved anxiety but not social interactions or language in ASD youth. Preclinical evidence by University of Missouri study found propranolol reduced anxiety in children and young adults with ASD after 12 weeks. An upcoming phase 2 trial, which has started in September 22, 2025, which is starting September 2025, showed propranolol for aggression or self-injury in ASD is being evaluated. Estimated completion at around December 2028. Just to summarize, we have propranolol, which is a beta blocker, reduces aggression anxiety, also useful for performance anxiety, which is used as an adjunctive agent under investigation. Valproate is used for mood stabilization, aggression control, useful in case of comorbid epilepsy, and you should always monitor liver functions and platelets. N-acetylcysteine, it's an antioxidant and glutamate modulator, which is shown to reduce irritability and stereotypy, has few RCTs and emerging evidence is noted, however. Levocarnitin. Now, this is studied in metabolic dysfunctions in ASD, and there is only some evidence for behavioral benefits. Other neurodevelopmental disorders which we are looking at is intellectual disability and Tourette syndrome, motor disorders. Now, intellectual disability, comorbid irritability, in case of intellectual disability, comorbid irritability, aggression, and self-injury can be taken care of in case of intellectual disability by other medications. The non-psychiatric medications which are used are anticonvulsants for mood stabilization, propranolol, melatonin for sleep regulation, and nutraceuticals are also used off-label with limited evidence. Tourette syndrome in motor disorders. Under motor disorders, there are few drugs which are used, which are non-psychiatric medications, of which clonidine guanfacine is shown to have tick reduction effect. Topiramate is seen as a tick suppression effect. However, cognitive side effects are common. Botulinum toxin is seen for local tick treatment, and magnesium B6 is often studied in small trials. However, one particular sentence is not enough to summarize magnesium and B6 in case of motor disorders or other neurodevelopmental disorders. As we well know, magnesium is such a pleomorphic metal and a pleomorphic micronutrient. It has around 20 different salts with which are having renewed evidence, which are having an upcoming evidence in neurodevelopmental disorders, and which deserves like a separate presentation itself. For example, bisglycinate salt, magnesium bisglycinate, magnesium taurate, folate, there is threonate. A lot of them have direct effect on the central nervous system, which is still yet to be evaluated in extensive data and extensive RCT to put forth treatment recommendations. Now, coming to integrative viv and cautions, which are to be exercised when you're going ahead with non-pharmacological or non-psychopharmacological medications in case of ADHD. Off-label use, definitely. This is something which is only used off-label. As of now, the extensive evidence is just upcoming, and this is why informed consent is very much essential, in which the client has to be taken into full confidentiality and everything has to be explained to the client, saying that this is the thing which is off-label. However, we can always start with these medications in addition to the stimulants. Evidence quality. Now, evidence quality is quite variable with newer drugs. RCTs are limited, hence limited knowledge and limited literature to go ahead with the full-blown treatment recommendations, which are not currently available. Monitoring should be continuous. Look for side effects and look for drug interactions. Very much important in case of a collegial environment is you need to have quite a lot of amount of multidisciplinary input. Now, we're looking at coenzyme Q, magnesium glycinate, magnesium bisglycinate, and that is something which is really coming up in a big way. However, in case of collegial environment wherein I work, I see it is very important for the children, for the students who are pursuing the academics, not have any kind of sedative side effects, which are mostly seen in case of with ADHD or comorbid depression with ADHD, wherein I have to make sure that the client is fully well aware of the side effects as well as input is sought from the psychiatrist, the interventional psychiatrist also. And by the functional assessment which we are looking at here, and by the functional outcomes which we are looking at here, I need to make a special mention of this is because not just symptom focused outcomes is something which is to be looked out for. Whether they are having a good functional improvement is something which is a top priority, especially in a collegial environment. Summary table for the target for the medications which are already discussed. ADHD, in the case of ADHD, medication class which is mainly seen in case of non-psychotropic medications are cognitive enhancers. A prominent example is modafinil. A target symptom is definitely attention. ASD, Autism Spectrum Disorders, anti-irritability medications. Most prominent examples are NAC, N-acetylcysteine, and valproate. Target symptoms of these drugs are aggression. Intellectual disability, mood stabilizers are the medication class which is commonly used and most commonly targeted with the target symptom of irritability. And you have the most prominent example of valproate. In tic disorders, I've had two agonists, of which guanfacine is targeting tic severity as a main target symptom. Future directions here. Now, here we are looking at biomarker-driven treatment, pharmacogenomics, repurposing of metabolic and neuroimmune modulators, and role of gut-brain axis in medication response. Now, this is quite something which is coming up. Gut-brain axis with respect to the different amount of probiotic bacteria, probiotic or prebiotic supplements are coming up with the added increasing evidence, one of which is Akkermansia genus, and other routine ones are Lactobacillus, Acidophilus, all of the Akkermansia also is one of the major probiotic bacteria which is under investigation for making sure that the gut-brain axis is evaluated, and at the same time the medication response is amplified, making sure the gut-brain axis is also repurposing of metabolic and neuroimmune modulators. There is a lot of evidence coming up in a big way. Pharmacogenomics, we all know, wherein we are looking at the differential at the seeing the relative improvement with respect to particular molecules in particular disorders when we are evaluating the pharmacogenomics, and biomarker-driven treatment is the next major advances. I would like to invite any questions or comments for this particular presentation.
Thank you so much, Dr. Rohit, for your interesting presentation. Now it is open for discussion. Any comments from the audience? There is a question in the chat box by Dr. Ipsita Basu. Could you please put some your
Sure.
experience with sulforaphane?
Sulforaphane. Okay. That's a molecule I don't have any experience with. However, I would like to know what would be the best way to go ahead and what would be the, one of the ways from other presenters.
Okay. Professor Renner, do you have any question?
Okay. Yeah, give me a second. Yeah, I would like to know how do you think you can manage with all this you, you know with all these things you don't think one drug will do that. Would you need combinations of drugs and how are you going to test them? Because I don't think that magnesium on its own will make a big impact. So the question is, will it be that we test for combinations and how do we test in combinations in randomized clinical trials? You need an awful lot of big trials to do the same stuff, isn't it?
Definitely. That is one of the major drawbacks due to which I believe the RCT data is quite limited because there have been a plethora of new directions which are coming up, and we're not just looking at different types of stimulant medications alone. And it's very easy to combine with respect to the different type of stimulants with a particular placebo or stimulants with non-stimulants to see that the person has a quantifiable clinical improvement or not. But when we're looking at different probiotics and prebiotics, also just looking at them, we need to see for different genus which are having that much amount of efficacy or not, which is comparable or which is at par with respect to the conventional stimulant treatment. And I believe multivariate RCTs is something which could be tried in this particular settings here with respect to, but it will require a lot of methodological challenges also will be a lot of forcing, is
Yeah.
what I believe.
I think we have the same problem with antipsychotic and antidepressant medication, where we just combine medication and we have no clue whether it works, and it just it's sad if we start this again, isn't it, over the years, because we should know better by monitoring individual people's effects and have possibly better statistical models than this A/B in a randomized clinical trial. But I'm not too optimistic about that. Okay.
Sure.
Is there any more questions?
Nope.
Thank you, Dr. Rohit. Interesting presentation. There is a lot of scope to understand